I welcome representatives from Canteen, Australian New Zealand Children's Haematology Oncology Group and the Kids Cancer Project. Welcome. Understand information on parliamentary privilege and the protection of witnesses and evidence has been provided to everybody?
Yes.
Okay. Thank you. For the Hansard record, could I please ask each of you to give us your full names and the capacity in which you appear? And Ms Anderson, I've been starting that end of the table.
Go ahead, that's fine. So, Susan Anderson, I appear as a witness in terms of a representative from the Kids Cancer Project, but also a parent of a child on this journey.
Peter Nielsen, I am the Director of Strategy and Partnerships at the Kids Cancer Project.
Luciano Dalla Pozza, I'm the Head of the Oncology Unit at the Children's Hospital at Westmead, and I'm a representative of the Australian and New Zealand Children's Haematology Oncology Group.
Chris Fraser, I'm a paediatric haematologist oncologist at the Lady Salento Children's Hospital in Brisbane and also the chair of the Australian and New Zealand Children's Haematology Oncology Group.
Welcome.
I'm Michael Osborne, I'm a paediatric haematologist and oncologist, and I'm the lead clinician of the South Australian and Northern Territory Youth Cancer Service.
Peter Orchard, I'm the CEO of Canteen, the Australian organisation for young people living with cancer, meaning 12 to 25-year-old.
Welcome. We have your submissions. Thank you. I'd like to invite you all to make, or whoever wants to make an opening statement. Then we'll ask you some questions. Have you spoken about who might kick off?
We haven't.
Canteen, go for it.
Thank you.
You're the top of the list.
Thank you. Canteen was established 30 years ago by 6 young patients. Since then, our remit has expanded to include siblings of young patients, as well as young people whose parents have cancer. True to our history of having been set up by young patients, to this day there are young people impacted by cancer guiding us at every level of the organisation, including the board, where the majority of the board directors are young people living with cancer. They are the majority shareholders, and so it is with their imprimatur that I and Dr Michael Osborne represent the interests of young patients 15 to 25 years today. We also work very closely with ANZCHOG and share very similar concerns to ANZCHOG and the Kids Cancer Project in relation to drugs for children and young people. Firstly, I want to acknowledge the incredibly important role that the Australian Government funding plays, which has been provided to Canteen through the Youth Cancer Networks program to support the establishment of specialist youth cancer services in hospitals across Australia in partnership with State Health. This funding has substantially changed the way that young patients 15 to 25 years receive treatment for their cancer diagnosis. We are also grateful for the Teleweb initiative funded by the Australian Government, which enables Canteen to provide 7 days per week professional counselling and 24/7 peer support online and by telephone to young people no matter where they live in Australia. Today, we want to emphasise how critical it is that there is funding for a subsection of paediatric and young patients to ensure that they have access to any innovation in the development of new drugs at the earliest stage possible. Because these children and young people are the ones that will die from their cancer. We will also talk about the vital role that research, in particular clinical trials, plays in driving improvements in survival rates. I want to thank the Chair, Senator Rachel Stewart, and the Senate Standing Committees on Community Affairs for the opportunity to speak today. Thank you.
Thank you.
Thank you for the opportunity to contribute today. My team, the South Australian Northern Territory Youth Cancer Service, is one of 5 youth cancer services across Australia, the Australian states and territories, and we provide care to 15 to 25-year-olds with cancer. The role of the Youth Cancer Service is to provide medical, psychology, social work and other areas of expertise specifically for teenagers and young adults with cancer, so that they not only have the best chance of being cured of their cancer, but also the best chance of going on to be healthy, productive members of society. I'd really like to echo Peter Orchard's acknowledgement of the crucially important role that the Australian Government has played in funding youth cancer services across Australia in partnership with state health departments. In my home state of South Australia, the team that I lead has contributed to the care of in the region of 80% of 15 to 25-year-olds with cancer since we started in 2011. This wouldn't have happened without the funding from the federal government, and for that we're certainly very appreciative. However, while the youth cancer services are making a substantial impact on the cancer journey for young Australians with cancer, 15 to 20% of them still die of their disease. And for each young person that dies of cancer, this is over 60 life years lost. Most cancers in young people are not preventable. Most cancers in young people are not detectable by screening programs, and the treatment of most of them absolutely relies on chemotherapy. Consequently, we strongly believe that our best chance of curing the remaining 15 to 20% will be new, innovative specialist cancer drugs. As you would have seen from our submission, many of the issues relating to new cancer drugs in teenagers and young adults are very similar to those experienced by our paediatric oncology colleagues, and our recommendations closely align with theirs. So today I hope that we can emphasise the importance of supporting clinical trial activity to investigate new drugs, the importance of legislative incentives for pharmaceutical companies to develop paediatric and adolescent indications for new drugs, and also the importance of further developing a centralised mechanism for conditional approval of new drugs that show promise for rare cancer subtypes that currently lack adequate therapeutic options. Thank you.
Thank you.
Thank you, Senators, for the opportunity to present today. As I mentioned before, my name's Chris Fraser. I'm the Chair of the Australian and New Zealand Children's Haematology Oncology Group. We are the professional body that represents medical and nursing and other healthcare professionals who are looking after children and adolescents with cancer in Australia and New Zealand. I guess we welcome the opportunity to put in a submission to this inquiry because we really feel that there are very unique aspects of childhood cancer that need to be emphasised when considering the issue of these new and specialised cancer drugs. By way of very brief background, childhood cancer is rare. It makes up in the 0 to 15-year-old age group, 1% of all cancer diagnoses per year in Australia. However, it's also one of the great success stories of oncology in that over the past 40 or 50 years, the survival rates, cure rates, have increased from less than 30% to now being about 80%. We certainly think that we're on the edge of a new frontier in oncology with new molecularly targeted therapies that are actually targeting the driving mutations that are causing cancer. And that's a very exciting time for us because at the moment, those cure rates of about 80% seem to have plateaued because I think the existing therapies that we have really reached their limits. So we don't have any doubt that the way forward in terms of being able to cure the remaining 20% of children who currently aren't cured is going to largely involve newer, molecularly targeted, innovative therapies. However, in applying those therapies to rare diseases like childhood cancer, there are a number of challenges to do with, particularly to do with access to the drugs, because there isn't an economic imperative for the pharmaceutical companies to develop these drugs for very rare indications. Clinical trials play a major role in this, and Australia has historically been a very active participant in clinical trials for paediatric cancer. And in fact, paediatric cancer clinical trials have become a standard of care for children with cancer. And it is largely due to this that the improvements from less than 30% to 80% survival rates have come about. However, with these new drugs and increasing involvement of pharmaceutical companies, running those trials is increasingly complex and expensive. And one of the messages which we hope to get across today is that our problem in paediatrics is not so much at the end of the PBAC and approving drugs for funding. It's actually getting the drugs there for specific paediatric indications and for that development to have taken place and to have the infrastructure in place in Australia for us to remain relevant in running clinical trials for children with cancer in Australia. So again, I thank you for the opportunity to present today, and I'll hand over to Dr. Della Pozza.
Good morning, and Senator Stewart and members of the committee. Thank you very much for the opportunity. I represent children with cancer today as well, and I appreciate the opportunity to participate in this particular inquiry to see how we can properly take advantage of a system that allows full and objective assessment, not only of new agents but technology in the management of children with cancer. As Chris has said, there's a new class of compounds or medicines that are becoming available to patients afflicted with cancer, and these require rigorous assessment, and past experience has shown that children tend to be left behind in that process, and I'd like to see a system that elevates their status, not to the back but to the front of that particular process, and I hope the inquiry can at least look at that aspect of it. Thank you very much.
Thank you.
Well, thank you very much, Senators, for holding this inquiry. It's a great opportunity to present the cases for children who suffer from cancer. The Kids Cancer Project is been around for 25 years. It's on a mission to deliver a cure for children with cancer and to end suffering. How we achieve this is through funding medical research and supporting children and families through the journey. One of our jobs is also to increase awareness. So while this committee is looking at access to availability of drugs, we hope that we do a little bit of education about childhood cancer and Senators walk away with some important information. We have had as I said, over 25 years as an independent charity, and over that time we've funded more than $24 million worth of research. Australia has one of the highest incidents of childhood cancer, but we also have one of the greatest success rates. But there is no prevention for children with cancer. So that way we see the best and most important way to improve outcomes for children with cancer is to support medical research and support clinical trials. You'll see in our submissions that we encourage the pharmaceutical industry participate earlier in the development of drugs when it comes to children and young adults. We also seek that there needs to be a streamlining of the regulatory processes so that children don't have to wait for new innovative drugs to go through adults and potentially wait years. And also we seek that clinical trials in children are recognised as an essential part of treating children with cancer. I go back to the premise, if there is no prevention, what do? We have to focus on how do we treat children with cancer. And once again, thank you very much.
Thank you. Ms Anderson?
Thank you. I also offer my thanks to all of you as part of the Standing Committee. I represent the views of parents on this journey, and I just would like to talk through the journey that they take, the paths that they follow, and then the questions that they really need answered through this process as well. A diagnosis generally brings about lots and lots of emotions, lots of questions, lots and lots of crippling circumstances. But if we move beyond that and we look at what it is that the system does offer them, it offers them a specialist who resides in every one of our different treating oncology practices around the country who have capability and also instill in that patient and in that parent a level of trust. I believe as a parent sitting on this side of the fence that certainly every one of our dedicated professionals out there has the right intention for their children, but I'm not convinced that the system is necessarily there supporting everybody to do their job the way that they should. A parent will question, who do I trust and why? What do they know? How many other children have they actually treated with this particular tumour type? And when we're talking about rare tumours, there's a chance that some of these specialists may only see 1, 2 or potentially even 3 in the lifetime of treating them. They are not necessarily always the authority on every single tumour type. So they go seeking knowledge. They go through an authority path, which means they obviously are working through the normal channels of what is offered within the medical system, but then they go through a channel or a pathway that is very informal. The authority one is fine. As I mentioned to you though, we do have issues around not necessarily having any central register or any conglomerated information about the number of patients around the country who do have that type of tumour and what their treatment protocol had been. I think that system is sound, but it's not necessarily properly enabled. The other side of it is the informality path where they go seeking knowledge, and obviously that's not going to be through a specialist, that's going to be through a network of parents all over the world who all have the same issue with their child. One example might be a child with a tumour that is ATRT, which has about a 10% rate of survival. They're not going to find a lot of other children in Australia with that circumstance, and so they go searching elsewhere. They'll get information, and that's actually a positive thing through social channels. It's positive because actually it gives them exposure to what potentially could be opportunities. When they find their potential solutions, there's going to be two layers to them. One of them is what's going to be offered through the hospital and the medical system, and the other is potentially what they've found through their own searches. What's offered through the standard system may be a protocol that is used and is funded locally, and what is available, and that's quite sound. I mean, that's a good starting point. But the challenge exists when that family is having to confront the decision around what could be offered somewhere else. That may be offered interstate, and another child paying the same amount of, or parents paying the same amount of taxes every year into the same Medicare system may not get access to the same drugs and the same protocol in one state versus another. They may look overseas and they might see that there's potentially trials over there that could well work for them and that they are showing, you know, some really good results. But they are limited by their access to be able to get international funding or funding through the Medical Treatment Overseas program because there's no proof of the fact that that is a proven treatment that would give the longest chance of survival. May be very good outcomes for them, but it may not be proven. So in the mind of a parent, as I sum this up, I say that they're out there, they're seeking, and they're seeking to try and find an answer. They're fighting levels of inconsistency all over the place, and most of that inconsistency is happening on a state-by-state basis, where children in some areas are offered access, where others are not, and that's purely based around being able to fund the drugs that are needed for them. They're also fighting against a system that centralises the support for them. If I was a parent who had a child with a very rare tumour, which I am a parent with a child with a very rare tumour, I didn't know anybody else who had a child with that tumour. I had to find them. Strangely enough, I found another one, and that came through a network of a family friend, actually, who ended up putting us in touch sometime after it. But there's not one spot where you can go and get centralised support for rare tumours. So in saying this, I think that the summary here is that we do pay into the same pool, we pay into the same Medicare contribution, but we have different levels of access. I would think that there are three pretty simple solutions within this, and that I would encourage the Standing Committee to consider, and that is that there's a central authority that can support parents and obviously practitioners out there in accessing those information on the clinical trials, that there's an appropriate infrastructure that's put in place to enable that, and that there is actually some subsidised funding that is considered separate for those parents who are facing very rare tumours, where it's never going to be a commercial advantage for a pharmaceutical company to offer that level of support, and also if that even comes through the MTOP process. I think finally the big thing for me is making sure that we have access and equity for all children in Australia to the appropriate treatments that they require. Thank you very much for listening.
Thank you. Senator Xenophon?
Can I just ask a question to the panel? Two things, and thank you, Ms Anderson, for your submission. I'll get back to that in a minute. But two things in terms of the streamlining of regulatory procedures, and I know they've been referred to in your submissions and your opening statements, and also the clinical trials. Perhaps to you, firstly, Dr. Della Posa, that in terms of clinical trials, how important is that in the scheme of things in terms of how we interact with clinical trials in the US, for instance? Can you just explain that to the committee, the significance of that, and also tying the issue of streamlining? Because it seems, from what I understand from the previous discussions I've had with you, in blunt terms, not talking about a lot of money, but the effectiveness of it can just be enormous.
Yes, they are. In fact, the gains in survival for many forms of childhood cancer, the majority, have been through clinical trials where one set of results seeds the next level of results, etc. So that we find that over a period of 10 to 15 years, improvements in survival rate go from 30% to 40% to 60%. A good example of that are children with neuroblastoma. We regard them, because of the way they're structured and developed, we regard the science behind clinical trials as to be of the utmost quality. What we find in Australia is that the clinical trials that are performed through every single major paediatric oncology centre is in fact funded through philanthropy. The 95% of the money going towards clinical trials or supporting clinical trials comes through philanthropy. And that's increasingly, it's difficult because it limits the number of trials that become available. The other important point here is that we are a group of orphan diseases, lots of rare types of cancers, and the only way we can conduct proper objective assessments as to whether new treatments are effective is to actually join in collaboration with other countries. And so all of the centres are in fact members of international consortia, the Children's Oncology Group in America, the BFM group in Europe, and together internationally we contribute patients where we can evaluate objectively whether treatments are effective or not. And then that seeds the next layer. That's been our primary driver. It actually maintains a very good platform of experience and intelligence and knowledge, education within Australia. The unfortunate thing is simply that we're out selling raffle tickets to support that sort of stuff, and that's really, really very, very crucial.
So can I just further to that? So you're busy selling raffle tickets when presumably you could be spending your time more wisely in terms of undertaking these trials. I mean, what are the blockages in terms of these trials taking place? How many additional, what's the optimal number of trials that could take place? And what do you see the impact? Because my understanding broadly is that if you can sort out issues of childhood cancer can often have impacts on adult cancers as well. Absolutely. In terms of breakthrough treatments.
I think that there's been a shift, there has been a shift, no, I don't think it, there has been a shift where treatments are no longer designed on the basis of what type of cancer it is, but rather what made that cancer develop in the first place. And that between adults and children, there are shared genetic mechanisms, and the increasing emphasis on drug development is how do you paralyse that genetic weakness in the cancer. So what works in women with breast cancer may very well work in selected subgroups of children with leukemia and vice versa. What works in various types of childhood cancer may very well play a role in adult cancer. So that's very, very important.
So what we're looking at the optimal number of trials in terms of the capacity for the researchers to do the research. I mean, how many clinical trials are there at the moment in terms of childhood cancer nationally, and how many more could there or should there be to maximise?
I'd have to take that. I have to go back into that, but at our institution we have 36 active clinical trials, and that caters for a lot fewer types of cancers, because there are some clinical trials which are designed to attack problems in children who have a first diagnosis, and there are other types of clinical trials that are designed to improve the outcome for children who relapse. So there's almost always a second layer of therapy that we can offer children. So it's rare nowadays for us to give up after one failed treatment. We will usually try something else. And so there's a series of different trials where we're either evaluating second-line therapy or trying to evaluate potential new agents. In terms of the staffing required, was that part of the question? We looked at the numbers in Australia at the moment. We have about 50 clinical trials support officers or data managers across Australia. We think we could deal with about 60 now, and the total cost for that is around about $6 million on a recurrent basis. And that enables the current portfolio of trials to be undertaken. Could we do with more? Absolutely. I think that a reasonable number that would enable children who have rare cancers to benefit and participate in trials across the world, the figure would be around 50 to 60.
So the $6 million a year, in blunt terms, would optimise what you can do now, and that will make a big difference in terms of the number of children that would have access to.
Access to, not only that, but would seed the information for the next generation. So what we learn today from these trials, the information is so robust that we can say either ignore that therapy or introduce it into frontline treatment. And that's why they're absolutely crucial.
Okay. I've got other questions, but perhaps later.
Okay, we'll share it around. Yeah. We've got a bit of time. Senator Billick.
Thank you. I'm not quite sure where to start, to tell you the truth. I would like to say, Miss Anderson, I think your daughter Audrey is unwell. Is she stable? Is that correct?
She is.
So,
yeah.
look, I just want to say we're all happy to hear that.
Thank
so,
you. I appreciate it.
Yeah, it's good news. Hope she stays stable and and continues to improve.
Yeah.
So,
Thank you.
yeah. Now, with the Dr. Fraser, I'll start with you if I can.
Sure.
Spotlight. You mentioned that the survival rate was good for kids with cancer.
Yep.
Bearing in mind more Australians die from brain cancer than any other disease, I'm a bit concerned about your comment. Are you able to expand on your comment?
So I guess, my comment is that at the moment, 5-year survival rates, which in paediatric cancer, a 5-year survival rate almost always equates to a cure, is at about a little bit over 80%. They're the figures. And that probably reflects the fact that the most common paediatric cancers fortunately fall into the more curable groups.
Yeah.
And so leukemia, acute lymphoblastic leukemia, is the most common type of childhood cancer that we treat. And fortunately, the survival rates for acute lymphoblastic leukemia have been increasing incrementally through the clinical trial work that's been done internationally that we've been part of. However, that still means that, even with those figures, there are still 20% of children who don't survive a diagnosis of childhood cancer, and certainly brain tumours are overrepresented in that group. And there are a number of other, because it's the most common type of cancer, leukemia is also quite well represented in that group as well, although proportionately more children will be cured. But there are a number of other solid tumours. The second most common solid tumour after brain tumours in children is a neuroblastoma, and that also often presents in more advanced stages, and cure rates are nowhere near as good as we would like to see for that particular disease either. However, I certainly stand by that figure of an 80% cure rate when you take all children diagnosed with cancer. But that does mean that there still is 20% of children who aren't cured, and that's in terms of life years lost, that's an awful lot of life years lost, and in terms of impact upon families and communities and the people looking after those children, that 20% of children has a huge impact. And that's the group where, we want to be able to move forward and be able to utilise these exciting new therapies that are becoming available. I guess that the clinic, if I can just expand a little bit upon the clinical trial story and how I see that fitting in for that group of 20%, up until this point in time, many of the clinical trials that we've participated in have been using old drugs in new ways, largely just increasing the intensity, the doses that we can give, and that has improved the cure rates. But as I said, we seem to have reached a bit of a limit there. And so particularly for cancers where the prognosis is nowhere near as good, including many brain tumours, or some types of leukemia that are resistant to our current treatment, the way forward does seem to be to use these molecularly targeted therapies. The problem we face is the drug companies. This is an incredibly small market, if you want to put it in those terms, and the drug companies are not looking to develop these drugs specific for paediatric cancers because it's economically challenging for them to have that sort of model. And so at the moment there are two ways. So we can look, as Dr. Della Pozza suggested, we can look at drugs that are used for an adult indication that may have some use in children. There's been a couple of exciting success stories in that area. But what we'd like to see is the pharmaceutical companies being encouraged to explore these opportunities, encouraged to run these trials in children, and especially being encouraged to try and develop new drugs specific for paediatric diagnoses. And that's something that, there's been legislative attempts overseas in Europe and the US to try and make drug companies either incentivise or even mandate that they test drugs in children. they haven't, you know, there've been successes with those legislative attempts, but there's also been, you know, significant failures. There are big get-out clauses, you know, where you can say, well, this diagnosis just doesn't occur in children, and so we don't have to test it in children. It doesn't say, you know, you really should have a good hard think about, could it possibly be useful in a particular small subgroup of children? And I guess, you know, that's something which we think is worth exploring, because at the moment there's no sort of legislation in Australia around that issue, the issue of actually, you know, incentivising or mandating testing of drugs in children. And so we run the risk, a lot of the trials that we've done have been through international collaborative groups, doctors like us, getting together at a meeting saying, we think this will be a little bit better. And pharmaceutical companies haven't been super involved because we've been using old drugs. Now we have to work much more closely with the pharmaceutical companies. And so there's partnerships. For example, Dr. Della Posa mentioned our partnerships with international groups, the US and Europe. They are increasingly having to partner with pharmaceutical groups. And whereas before we still are a very valued member of those consortia, now it's the pharmaceutical companies deciding, are we going to run that study in Australia? Because it's not, again, it's cost them more money. You know, they're working together with the collaborative groups, but ultimately they're getting to decide, you know, whether particular studies get open in Australia or not. And so for many years, it's only relatively recently that, you know, it's been an issue for paediatric oncologists. I think, you know, you could really look your patients in the eye, and it's that 20% that we're talking about. The others are doing very well. But you could really look your patients in the eye and say, I don't think there's anything anywhere else in the world really that, you know, you're not getting in Australia that provides us with a realistic chance of curing your child. But, you know, in the last few years with a lot of these new, not a lot, but some of these new therapies coming on board, and I think there's going to be increasing numbers, that's becoming increasingly challenging. Parents are very aware of these therapies through the internet, and so they should be. We're very aware of them from going to meetings and things like that. And it's, you know, we feel like we need to position ourselves to maximise our ability to access these new therapies. And at the moment, we're being, you know, a little bit at the mercy of the pharmaceutical companies as to whether they want to open these trials in Australia. Because at the end of the day, from our point of view, from paediatrics, you know, this starts at having the clinical trials open. That's the earliest time that patients can access these new exciting therapies. You know, the reimbursement and the PBS subsidies and things like that, you know, that's an issue for us as well. It's a big issue, and hopefully we'll get a chance to talk about that as well. But the first thing is really having ourselves set up so that we're, you know, have the infrastructure in place, and the drug companies want to include us, and we can stay at the forefront of worldwide treatment the way that we have been.
I will give you an opportunity in a minute to talk about reimbursement and PBS issues, because I do know how important they are. But can I just clarify, when you talk about old drugs for new ways, you're talking about drugs that are being clinically tested for adults, is that correct?
Yeah, so I guess...
But being able to use in a different...
Yeah.
Sorry, in a different... When you say in a new way, can you just quickly tell us what you mean by that?
Yeah, so conventional chemotherapy drugs, yes, they've been tested in adults. They've been registered with the TGA. They're on the Australian Register for Therapeutic Goods. They'll have a particular indication on the Australian Register of Therapeutic Goods, and usually that's an adult indication because that's where the tests have been done. But, you know, as paediatric oncologists, we can still prescribe those drugs, and many of them are subsidised through the PBS as well. But they're sort of, you know, I guess that's the way, you know, that's been the same armamentarium of chemotherapy drugs that we've used for the last 20 or 30 years. And in terms of using them in different ways, it's just a lot of the advances have come in terms of being able to give bigger doses with supportive care. We have better antibiotics. We've got medicines that can reduce the risk of infection. And so a lot of the improvements, particularly, you know, for example, in leukemia, have really come through using drugs that were initially tested in adults, have been used in children for many years. and we're prescribing them and manipulating the way that we administer them, and it has resulted in incremental improvements in survival that appears to have plateaued off in the last 5 to 10 years, because we think we've reached that limit of what we call dose intensity.
Can I give you another example?
Please do.
The simple sequencing of drugs, of medicines every 2 weeks rather than every 3 weeks led to a significant improvement in cure rate for children with rare forms of bone cancer. Just giving it every 2 weeks rather than that way. That was the trial.
Yeah, that's a new way. Okay. Now, do you just want to comment or make any suggestions you might have in regard to the reimbursement and the PBS issues that you just mentioned?
Well, I guess that the challenge that we see that we face here is the issue of the rarity of the disease. And I guess the way that the system works currently, there aren't, I'll be honest with you, there aren't real regulatory roadblocks for us to access drugs and prescribe them to children if we can get hold of them somewhere, which you usually can, as long as they're out of that very early phase of clinical trials. Someone overseas will, a company, if it's registered somewhere, will generally sell that to you. But if it's not registered in Australia, through the TGA's SA, Special Access Scheme system, we can prescribe that drug to a child where we consider that, it's an otherwise life-threatening condition. And we do that, and I must admit that, as a paediatric oncologist, the ability to access drugs overseas or, to get new drugs if they are available beyond that earliest clinical trial phase, isn't a huge problem for us. The problem then is who's going to pay for them, because they're obviously at that stage, they're not listed on the PBS, and in fact, very, very, very few chemotherapy drugs or the new anti-cancer drugs that we're talking about as part of this inquiry are actually useful at all in paediatrics. I was having a look at the PBAC and the Department of Health submissions to this inquiry, and they listed an example of 14 drugs that were recent anti-cancer therapies that have been recommended for approval by the PBAC. And there was one drug that, was of use in paediatrics, for example. And so I guess that, many of the drugs that we're interested in, if they are listed on the PBS, they're not listed for a paediatric indication, so there's not going to be subsidy there. And so the way that we give these drugs to our patients currently is we have to each apply to a drug utilisation committee or the hospital executive of our individual institution. And there's only 8 institutions in Australia that treat all the children. The young adults are a little bit different, but I mean, amongst children, there's 8 institutions, so it's pretty, it's a pretty well-contained specialty. But within those, each different state, each different hospital executive has a different threshold of what they're prepared to pay and what they're prepared to approve. And this speaks a little bit to what Sue was saying. We struggle a bit with that inequity if we know that there might be a patient in South Australia where the hospital has said, yes, you can have drug X, which will cost $40,000 a year. And when I have a similar patient and I go to my hospital executive, if the budget for that year is looking particularly stretched, as they often are, the state-based hospital operational budgets, they're just as likely to say no, and sometimes they do say no. And so I guess what we feel is that for drugs, and the problem is to get to that PBS approval, proving clinical and cost effectiveness in very small patient groups, extremely small patient groups, the data is almost never going to be available, and the economic incentive to try and collect the data is not going to be available. It's far, the drug company is going to say, let's apply for a listing for breast cancer. They're not going to be worried about a rare, liver tumour in children. And so I guess at the moment our system is we have to beg our hospital executives to pay for these drugs, and they may or may not approve it. There are inequities amongst different states' thresholds. And so we think that there needs to be some, in the rare diseases, like every childhood cancer, just about, we feel like there needs to be an improved mechanism that assesses the eligibility for federal funding or federal subsidy for these drugs that doesn't rely upon extremely stringent clinical and cost-effectiveness data and is not subject to the vagaries of individual jurisdictional approval. I must admit, in reading the Department of Health submission, they mentioned a managed access program for this very situation where, drug companies would be given a conditional approval and there'd be subsidy associated with that. And in the Department of Health submission, I think they make the point that this needs work and it's not working very well at the moment. And I must admit, as a clinician, reading through their submission over the weekend was the first time I've heard of that program. So, I was unaware that there was even...
don't know it exists.
I was unaware that there was even a program that existed where, that could try and address the problems that rare diagnoses like the ones we're dealing with have. And so, I guess what we would like to see is, some sort of system that recognises preliminary evidence of clinical effectiveness. There are drugs coming online, these new agents of drugs for leukemia. Again, I'll use that example, where children that otherwise no chance at all of being cured, nothing else is working, and there's a new drug called blinatumomab, for what it's worth, where single agent therapy is getting children into very good remissions in about 40% of patients, 35 to 40% of patients who otherwise would have no chance of survival. And once they're in that very good remission, it doesn't mean they're cured by that drug, but it gives you then the potential to go on to a potentially curative therapy like a bone marrow transplant. So maybe that 30 to 40% aren't going to be cured, but I would venture to guess, and I know from preliminary data, that a significant percentage of them have a realistic chance of being cured. And that drug, all the early phase trials are being done in the US and Europe. Australian children have not been able to access that drug. And in some ways, that's because the drug companies, the most exciting drugs and the ones that they think have the most profitable potential, they guard them more closely. They're going to accrue well. They're going to get enough people on the studies in the US and Europe. And so they don't need us to enrol kids on those sort of studies. And there's no legislative or other sort of thing saying, well, if you want to sell that drug in Australia, you should include Australians on the study.
Are you saying there ought to be a legislative mandate that is part of almost like a community service obligation of drug companies? I know there's been a lot of money in research that in those cases you ought to require as part of any approval that there ought to be some of those clinical trials that you've referred to.
I think Australian regulatory authorities should recognise the fact that there is a real shortfall in this is a global problem, in the drug testing in children. And to be honest with you, it's probably not only cancer. I mean, cancer is probably the most emotive issue because it's life-threatening. But globally, in the EU and the US have very much recognised this and have made several legislative attempts to try and mandate that children are included and drugs are tested. And I guess that, you could argue that Australia runs the risk of being a bit left behind if we don't try and enforce that. Australian children run the risk, and young adults run the risk of being a bit left behind if we don't try and enforce something along those lines.
Can you just give us some more on notice? Can you provide us some more details of that?
Sure.
Thank you. Sorry, Chair.
Senator Brown?
Well, I was going to go and ask about the mandating as well. But a lot of the submissions talk about incentives. Can someone clarify what they mean by that?
Oh, in the US, what they do with drug companies to look at orphan disease, they try and give them an extension of patent, right? But there's also a mixture of mandating as well. So in Europe, they provide a mandate, you must provide childhood cancer trials or whatever, but we will also give you an extension on your patent life. And that can be 6 months to 1 year.
So has the issue of mandating been raised with pharmaceutical companies? Have you had discussions with?
Well, not in Australia. I think that, our interactions with pharmaceutical companies, to be honest with you, is we take what they give us. If they want to involve us in a trial, we say thank you very much, and we do our best to open that trial and run it within the confines of some of the restrictions of funding that we have. But we haven't been directly interacting with pharmaceutical companies, along those lines.
I think, having said that, the global offices of the various pharmaceutical companies would be very aware of the concept of the PIP program in Europe. They'd be very aware of the similar regulatory requirements in the United States as well. So while there might not have been the discussions at a national level, the global offices of pharma companies would certainly be aware of these things.
Thank you.
And the TGA is aware of them as well. And the TGA has tried to harmonise a lot of their processes with the EMA, the European Medicines Association, and the FDA. And they do, in the TGA submission, they do ask, is there a paediatric plan in place? But it's not required, and so in many ways, the TGA is trying to harmonise their approach with what the Europeans and the Americans are doing, but it's not legislatively required here in Australia.
I wonder, do you have any information, probably won't have it available here, about when there was companies were mandated to do certain things, what their reaction was?
Some of the legislation in the US provides waivers, and some of those legislation, there's more waivers than there are drugs going through to children. And I know that if you want to make real change, you really should be looking at partnerships. And that's why we balance it up, because historically, if you look at Europe and you look at the US, they have used that mandates, but they're very different markets than Australia is. I mean, pharmaceutical companies, they develop drugs for those markets. Yeah. So it might be easy for them to mandate, where we really should be looking at how do we work together to gain access for children.
The other thing that I wanted to ask about, and I'm not sure whose submission it is in, but it's about the streamlining the process of the ethics review and site-specific governance to minimise delays in opening clinical trials. Am I in the right?
Well, I think that in order to run successful clinical trials, the amount of regulatory requirement has certainly increased over the years. I'm certain that Dr. Della Posa could, speak to the changes that you've seen during your career in terms of what's required, not just at the ethics level, but also going through hospital research governance, getting multi-site ethics approvals and so forth. For instance, at my institution, just recently, I've opened a non-drug study, and from the time that I submitted it to the ethics committee through to the time that we finally were able to sign off on it, was close to 6 months, and that's for a non-drug study. Drug studies will potentially take significantly longer than that as well. To be fair, there have been improvements nationally in terms of streamlining the process. Once upon a time, for some of these studies, every hospital would have to put it through their ethics committee, put it through research governance. In more recent years, there's been multi-site ethics reviews, but still each hospital then needs to put it through their research governance office, which then takes longer, and a lot of those steps which, to be fair, were put in place to protect people are in fact delaying access to drugs there, and they're inhibiting our ability to put patients onto new trials. So I think that this is a related issue, and it's certainly something we've all tried to address. It probably isn't the crux of the issue for today, with the crux of the issues for today being more those of improving clinical trial infrastructure. For instance, if we had more of the clinical research assistants that Dr. Della Posa spoke of, some of those processes would be much more manageable. Putting a trial through at the moment is what I do after hours. Having more staff on board would facilitate this to be done in a quicker fashion. the other crux of the issue today is, as Chris has said, looking at legislative requirements or incentives for pharmaceutical companies to develop paediatric indications. And also the other really important thing that I think we need to be talking about today is having some kind of centralised conditional approval process like the Managed Access Program that's promoted to doctors looking after children and adolescents and young adults with cancer, which offers a way for us to access these drugs at an early stage so that we in Australia are not left behind compared to our colleagues overseas.
Okay, thank you, Dr. Osborne.
Senator Paris?
Yeah, I've just got a couple of questions from your recommendation that you've made to the committee. One of them is the encouraging the pharmaceutical companies to lower the age eligibility from 18 to 15. How can we achieve that? What do we need to do?
This is a concern which oncologists who look after adolescents and young adults around the world share. At a meeting last year in London where there were adolescent and young adult oncologists from Australia, UK, much of Europe and the US, there was broad agreement that this is a problem. For instance, at the moment, if there was a 17-year-old with relapsed acute lymphoblastic leukemia who we thought would benefit from a drug like blinatumomab that Chris mentioned, they realistically couldn't get it. If they were 18 and being treated in the adult hospital up the road, which is running a trial of this, they can. I see that as being a major issue of equity. Many pharmaceutical-sponsored drug studies have strict age eligibility. They'll say patients need to be aged between 18 and often they'll say 65 or some other upper age limit. And what that effectively does is it restricts younger patients who may benefit from that drug from accessing the drug. So I think that having a lower age eligibility criteria is a real problem, and it certainly creates an issue of inequity, and it also means that younger patients can't get something which someone who's a bit older could get. So I think that the issue of age eligibility is something which internationally is a concern, and certainly in Australia we could potentially be looking at leading the way in saying that this is something which needs to be justified rather than accepted as the norm as it currently is.
Okay, and the other I've got two more questions. Establishing legislative incentives for pharmaceutical companies to develop paediatric and adolescents indications for new drugs. What would that look like?
So I think that, as Chris has already spoken in quite a detail about, in Europe they have the paediatric the incentive program, the PIP, and in the United States a similar program to try and encourage pharmaceutical companies to develop specific indications for children. They ask them, could this drug be used in children? And often they'll say, well, this is say a melanoma drug, children don't get melanomas, therefore no. Whereas in actual fact, the drug might be targeting a particular genetic lesion, like Dr. Della Posa spoke about, which, yes, it occurs in melanoma, but it also occurs in childhood brain cancers. So what we should be asking the company is not, does this disease occur in children, and then they say no, giving them a waiver, but rather, could this drug be used in children? And if they are answering honestly, they would have to say, yes, it could. And what we could do is either take the line of offering incentives, such as an additional 6 months of patent protection, or we could look at some sort of mandate. And different jurisdictions around the world have taken different lines, and there's probably no reason why you couldn't incorporate both. As Chris mentioned, these programs have not been perfect. They've not improved things in children to the extent that we would have liked. But I guess the advantage that we have in Australia, if we were to look at setting something like that up now, we could learn from what's happened in the US, we could learn from what's happened in Europe, and hopefully try and build upon their learnings in developing a similar system for Australia.
Okay, thank you. And just finally, if you can elaborate on, I think it's recommendation number 3, the need for greater transparency of the PBAC drug pricing policy.
I think that one thing which has also been mentioned in some of the other submissions is that a lot of the discussions around cost effectiveness and so forth when pharma interacts with the PBAC is not on the public record. And I think that, like the PBAC said in their submission, we think that it would be valuable if that was more transparent and more readily available.
Certainly, sorry, Senator Perez, that was one of the recommendations in the PBAC was greater transparency of those interactions they have with pharma around the information that pharma provides, that the PBAC then makes their decision in relation to acceptance.
Thank you. Thank you, Chair.
Senator Xenophon, you said you had a few more if we had
Just very briefly, so is it a case that pharmaceutical companies, you haven't approached pharmaceutical companies, or you've got indication from overseas that they won't cooperate, or what? Because I think that there's a lot of goodwill on their part to advance this. So is it worth a fresh approach to pharmaceutical companies trying to expand these trials? Because it seems to me that for the sake of $6 million a year, you could actually increase significantly the benefits to kids with cancer.
Look, I think part of the challenge is that there isn't a national sort of structure to do that. ANZCHOG certainly is there for the health professionals, but in terms of an infrastructure to engage with the pharmaceuticals as a group, as a body, that's a major piece of work, I think, Senator, to try and get to a position where you could get this.
Do you think the Commonwealth can play some facilitative role?
I genuinely think the Commonwealth could play a role here.
Through what mechanism?
I think so. The funding, for example, that the Commonwealth has provided for the Youth Cancer Networks program is an example of how the Commonwealth is contributing nationally to harness the expertise on the ground at a national level and to shape the research agenda for adolescents and young adults at a national level. That infrastructure isn't in place for children, and I think in terms of research it's not quite there for AYA either, but having that infrastructure then allows those dialogues to happen and to coordinate. You know, essentially we're talking about rare cancers, a small population, to coordinate the activity that's happening and to have those dialogues with pharma and sort of, I think the federal government playing a key role in facilitating.
Have you approached the federal government in respect of that?
Not on this particular issue at this point.
If you could, on notice, provide that. I mean, I think the idea of this inquiry is to come up with some practical outcomes. Yes. We hope government will implement a number of them. That's the aim. Yeah. So thank you.
And any other, I think also to add to that, any other thoughts to build on what's happened overseas? Because you said yourself, Dr. Fraser, that's not working perfectly. So anything else?
In terms of best practice.
Sorry?
Best practice.
Best practice, yeah. Or you know, some innovative thoughts that we might like to toss around to suggest to the government would be useful as well. But obviously, there's a lot in your submissions, but anything else that this discussion's provoked would be useful. Any other final questions, folks? No? Okay. Thank you very much for your submissions and your time today, and your homework that you've undertaken is very much appreciated. Thank you very much.
Thank you.
Thank you.
Have a great day.
Sorry?
Have a great day.
Thank you. It's extremely interesting day. Yeah. Could I please ask